So let's get started with talking about the immunity during stroke. And as always, I'll try my best to make it as easy as possible. Let's get started with the first slide. So, before we start and get into the immunology, I want us to first understand why the stroke management is actually difficult. Why is it such a major challenge? We have three important limitations that I need to discuss. First of all, the time limited. Now, we know that the treatments we currently have are most effective when they're given early after the stroke. So the therapeutic window is quite narrow. So the time is the most important factor. Second, there is a risk associated with treatment. So, for example, whenever we talk about the thrombolytic therapy, it can be life-saving, but one of the major complication here is bleeding in that case, which includes, for example, intracranial hemorrhage. And lastly, we want to talk about how our current treatment mainly focus on restoring the blood flow or, for example, removing the clot, but they don't actually target the underlying inflammatory or immune process, which by that means it continues the damage to the brain after the initial ischemic effect. So we have the lack of targeted therapy to the specific process that's underlying this. And the last point that I want to discuss is that because stroke doesn't actually just cause an immediate injury and then stop, the immune system continues to respond over time in that case. So, for example, patients who have stroke also have a increased risk of pneumonia, actually. And other than that, we need to discuss and organize the immune response into three phases in this lecture, which is the acute, subacute, and chronic. Now, the easiest way to remember the entire lecture is what? I'll just give it to you as a keyword. Whenever we think of acute, we need to think of immune activation. And whenever we think of subacute, we need to think of immune suppression. And whenever we think of chronic, we need to think of systemic inflammation. Now, keep these three patterns in your head, and we're going to follow up with the next slides and the upcoming slides. So, now we have the neuroimmunology. Now, before we can continue forward with this lecture, we need to place the stroke into a bigger picture for us to understand it. We know that this topic falls under the term neuroimmunology. Which means what? We're studying the interaction between the nervous system and the immune system. This is immune system and nervous system. And we usually think of the brain as being like a protected area from the immune system or like immune privileged. But actually, whenever we think of stroke, okay, it shows us that the brain and the immune system, they're communicating actually very actively in that case. And we have other neuroimmunological parts, which include, for example, infections, Neisseria, Parkinson, Alzheimer, inflammation, or even the CNS immune privileged sites. It's very important to know that the brain injury, it will affect the immunity. So brain injury will affect the immunity, okay? And the immune response also can affect the brain. So this is the learning objectives. I will skip the learning objectives. So let's start with the basics about the stroke. What do we need to know about it? Very important. We need to know that globally, the stroke is the second leading cause of death, and it's actually number one of the causes of long-term disability. And something particularly concerning that we're seeing an increase in stroke among younger people mainly. So younger people are more affected by the stroke. This is closely related to the increasing prevalence of conventional cardiovascular factors as well. And by talking about that, we need to recognize some major risk factors written here, such as the hypertension, obesity, hyperlipidemia, smoking, and substance abuse. So whenever we see a patient who have multiple vascular risk factors, these are exactly the factors that increase the risk of the cerebrovascular disease. Okay, now let's move on and talk about the two types of stroke. which are very important to distinguish between. So the first one is called the ischemic stroke, which is the most common one, and it accounts for 70% of the cases. Here, the basic problem is what? It's an occlusion of the cerebral artery. What does that mean? It means that the blood flow to a particular area of the brain is interrupted. Now, the occlusion here can happen because of, for example, thrombosis. And thrombosis, we means when there is a clot that is forming in a vessel, or because of embolism, where we have a clot that is actually traveling, okay, from somewhere else and it's blocking the cerebral circulation. So the cerebral circulation is being blocked. A very important cause of the embolic stroke in this case is arterial or atrial fibrillation. Because the atrial fibrillation, it can lead to a thrombus, okay, in the atria. And this thrombus can actually travel and go to the brain. The second type is called the hemorrhagic stroke, and instead of the problem being like a lack of the blood flow or occlusion, here we have what an actual bleeding in this case. So the hemorrhage can happen in the brain substance, like in the brain parenchyma, or even in the subarachnoid space. And the hemorrhagic strokes, they're less common or less frequent, it's written here. And they're much more fatal. Why? Because we're actually having like an actual bleeding. So now let's move on with the next slide. Now we need to look at what actually happens inside the brain during an ischemic stroke. Ischemic, we said we have two types, yeah? So the reduction in the blood flow is not actually uniform or not actually the same throughout the entire area. The blood flow is not the same, not the same. And instead, we can think about two important regions here, the ischemic core and the ischemic penumbra. So ischemic core and the ischemic penumbra. The ischemic core here is the center of the injury. And the reduction of the blood flow is so severe that the cells, they rapidly undergo irreversible damage and then they eventually die. And surrounding that core is the penumbra. So what surrounds the core is the penumbra. The blood flow here is also severely reduced, okay? So the neurons, they actually cannot function normally. The neurons are not functioning normally. So they basically shut down their activity to conserve the energy. But uh, but the cells are still viable here in this case. So again, we have here the ischemic core and here we have the ischemic penumbra. The ischemic core, as I said, again, we have what? Severe reduction in the blood flow. It will lead to the cell death. The cells are dying in this case. But in the ischemic penumbra, which is surrounding the core, here we have a severely reduced blood flow, but the cells, they are still viable. They are still viable. So the penumbra is salvageable tissue. It's still able to be recovered. So this is why the penumbra is most important, the one that we talk about here. So our goal in treatment is to preserve the viable tissue. Okay, we need to preserve this viable tissue and prevent the infarction from expanding into it. And now this brings us to the topic that because inflammation can lead to secondary injury and potentially turn this treatable tissue into permanently damaged tissue. So this is because of, for example, the inflammation. Okay, so this is our goal to save it. Now moving on, let's talk about the inflammation and the secondary brain injury. So after the initial ischemic injury, the damage won't stop, obviously. So the stroke will actually activate an inflammatory response, and this inflammatory response will lead to secondary brain injury. We have two important cells here, which are the microglia and the astrocytes. When the brain tissue become injured or damaged, these cells, they will become what? They will become activated and they will participate in the inflammatory response. So they will participate in the inflammatory response. Now, the inflammatory biomarkers can also appear, but these biomarkers, so the inflammatory biomarkers, they will appear within minutes to hours, depending on what? Depending on two things, the size and the severity. So it depends on the size of the stroke and the severity of the stroke. The inflammatory response can actually involve pro-inflammatory cytokines and activation of what additional immune pathways. So you have to think about the stroke having two components. What are they? First component is the initial ischemic ischemic injury. Okay. Then on top of that, we have what? The inflammatory response that actually lead to this damage or further damage. And this is why the researchers, they're mainly interested in something called the immunotherapy. The idea here is not to restore the blood flow, but also to control the immune response, because as we said, once it starts, it will continue further, further, and further. Okay. So it's our main goal not only to restore the blood flow, but to also control the immune response to reduce the second injury and hopefully preserve what we talked about here, the penumbra. Okay, preserve more of the ischemic penumbra. So I hope this slide made sense for you. Let's move to the next slide where we are going to talk about the reperfusion versus the immunotherapy. So why are we even interested in immunotherapy when we already have like certain treatments for the stroke itself? Now, the conventional treatment, it includes what? It includes what? Thrombolytics and endovascular thrombectomy. These are extremely important treatments. Why? Because they are restoring the blood flow, or they actually remove the clot. But the major limitation here that they're strictly time sensitive. Time sensitive, as we said in the beginning of this lecture, we need to pay attention to time. So they have to be performed within like an appropriate therapeutic window, particularly during the early hours of the symptoms. And the thrombolytic treatment also carries what? A risk of bleeding, hemorrhage. Now, for the immunotherapy, it's attractive for a different reason. We need it for a different reason. We need to know that the immune system is not involved only during the initial acute phase, but also during the subacute and the chronic. So the immune system, we see it in the acute, subacute, and the chronic phases of the stroke. So we need to target the immune system to allow for a longer therapeutic window. We need to extend the therapeutic window, make it longer for us to be able to fix it on a deeper level. It may also have what? Lower risk of hemorrhage and complication in regards, if we compare it to the thrombolytic, it will have lower risk of hemorrhage and lower risk of complications. Okay, and it could potentially target several different stages, so target different stages of the stroke, not early stage, for example, such as the thrombolytics. So we're not saying that immunotherapy replaces the reperfusion or the conventional therapy, but the idea here about talking the immunotherapy, about talking about it's that it could potentially complement this existing treatment by targeting the immune response that continues after the initial vascular event. So it's improving it on a long-term recovery. It's extending the therapeutic window. So it's not as in like we cancel this and take this. No, this and this, they are complementing each other. Now let's move to talk about the three-phase immune response. So we're going to get to the core of the concept of this lecture. So the immune response after stroke is not just a single response. We need to know that it's multi-phase or multi-process cascade that changes over time. The first one that we start with is the acute phase, which occurs within what? Minutes to hours. And this is mainly characterized by immune activation and inflammation. So we see here the immune activation and also inflammation. Let me just write that here. And then we move to the subacute phase, which is the second phase, which is from hours to days. And interestingly, instead of continuing to become more inflammatory, the immune system here becomes suppressed, immunosuppression. So put this in mind, this is important. Okay. And then after that, the last phase is the chronic phase, which can occur from days to months. And we can see what? Persistent systemic inflammation. And what can we see here? Adaptive immune responses. So let me just write that. We can also see adaptive immune responses. So if you remember nothing else from the lecture, I just want you to remember this sequence that in acute, I'm going to have the activation. And in a subacute, I will have suppression. And in the chronic, I will have the inflammation. Okay, so let's start with talking about the acute phase more in depth. What happens within minutes to hours? So we need to know that the ischemic core, it contains stressed and damaged and dying cells. This is in the core. When these cells, they undergo the process of necrosis, okay, they will release for me the damaged associated molecules, so the DAMPs, okay, so damage associated molecular patterns. So we need to think of these dams that they're being released as they are called the danger signals. Danger signals. They are released from the damaged cells, and these damaged cells, they are in the core. Okay? Now, these dams, they will activate for me what? They will activate for me the glial cells of the brain, such as the microglia and what? The astrocytes. So it will activate for me the microglia and the astrocytes. And when it does that, at the same time, the blood-brain barrier is being disrupted. It's being disrupted. So at the same time, these two are happening. This is extremely important because we know that the blood-brain barrier, it helps separate the CNS from the systemic environment, right? So once it becomes disrupted, what will happen in this case? The DAMPs and the CNS antigens, they will go to the circulation. So the DAMPs with CNS antigen, they will go to the systemic circulation. And now the peripheral immune system can detect these signals and it will become activated. Once it become activated, what our body will react to it? How our body will react to it? It will give me pro-inflammatory cytokines and it will mobilize for me the leukocytes as well. Okay, it will mobilize it from the spleen and the bone marrow. So if we want to wrap it up, we will say that I have cell death. Okay, and then it will give me the dumps. The dumps will activate for me the glial cells, which are the microglia and astrocytes. The blood-brain barrier will become disrupted. It will go to the systemic circulation alongside with the CNS antigens, and then it will give me inflammation. Okay, pro-inflammatory cytokines and leukocyte coming from the spleen and the bone marrow. Now let's move on talking about the CNS antigens and the autoimmunity. So this is also another consequence, okay, of the blood-brain barrier disruption. Normally, many CNS antigens, they are hidden from the peripheral nervous system. We know that they are hidden because these antigens, they are sequestered and they may not have been fully represented during the thymic negative selection. Okay, so they're sequestered, they're hidden because of the thymic negative selection. So whenever we have the blood-brain barrier disruption, which happens after the stroke, okay, the previously hidden CNS antigens, they will enter the circulation, they will become exposed to the peripheral immune system. The immune system will see them, okay? They will see them as antigens in a completely different way. And this will activate what? The immune cells against the brain tissue. So I'm gonna have an autoimmune reaction against our own tissue, against the brain tissue. This is one of the mechanisms by which the stroke is leading to an autoimmune reaction, autoimmune response. Now, don't think of it as like every patient who have stroke will have autoimmune reaction. It's not like every patient who have stroke will have autoimmunity, okay? What is the most important concept here is that stroke will expose these CNS antigens that are normally hidden. They will be exposed to the peripheral immunity, which will give me autoreactivity and autoimmunity. Now, let's talk about the subacute phase, which occurs between hours to days. And this is where the immune response almost will go in the opposite direction. I call it the up phase, the opposite direction. Now, after the initial inflammatory activation that we talked about, the patient can develop a state of what? Immunosuppression. That's why I called it the up phase. This is called stroke-induced immunodepression syndrome, SIDS. Why does this happen? The stroke itself, it has what representation that tells us it's a physiologic stress. Now, don't mind this. This is like a mistake. I forgot to delete. So again, the stroke is representing for us physiological stress. That stress, it will activate the sympathetic nervous system, okay, and the hypothalamic pituitary adrenal system. So it will activate sympathetic and hypothalamic pituitary adrenal axis. The sympathetic nervous system, okay, it will release for me what? The catecholamines, while the HPA, it will release for me the glucocorticoids, especially what? Especially the cortisol. And these neuroendocrine signals, they will suppress or stop the immune function. Now, one of the most important findings is the lymphopenia. The lymphopenia. What does it mean? It means major reduction in the lymphocytes, particularly the T cells. So the T cells will be majorly reduced. At the same time, the body shows what it shows the emergency hematopoiesis with increased production of myeloid cells. So I'm going to have an increased production of myeloid cells. And the monocytes will show for me a reduction in the MHC class 2, which makes it less effective in presenting the antigen and providing the appropriate co-stimulatory signal. The overall is an immune system that is much less capable of a response. It's obviously immune suppressed. And this is explaining why the patients become highly susceptible to secondary infection. So, whenever we have a patient in the subacute phase, they're highly susceptible to secondary infections. Okay, now let's talk about T helper 1 to T helper 2 shift. This is another important feature of the immunosuppressive phase, okay, of the immunosuppressive phase, which is a change in the T helper response. Normally, the T helper ones, they're associated with what? Pro-inflammatory immune response. But after a stroke, there will be a shift between the T helper 1 and it will turn into T helper 2, which is more anti-inflammatory. So we see a reduction in the pro-inflammatory, such as the interferon gamma and the TNF alpha. And at the same time, we see an increase of the anti-inflammatory interleukin 4 and 10. They will increase. This shift is not always bad. Is it always 100% bad? No, it's not always bad. From one perspective, whenever we think of suppressing the inflammation, it can help protect the brain from the immune-mediated damage and reduce the risk of autoimmunity. But on the other hand, when we are suppressing the immune system, the patient become more vulnerable to infection. So it's like not fully bad, not fully good. So we need to remember that it's like double-edged sword, okay? Double-edged sword. So TLP1 to TLP2 means less inflammation but more infection risk. This is what we could take from it. Now, let's move on and talk about the mechanisms of the immunosuppression. How can this happen, actually? Now, there are three neurogenic pathways that are involved. The first one that I want to talk about is the sympathetic nervous system, or the SNS. Now, the stroke, it increases the sympathetic activity, causing catecholamines to circulate and act on the adrenergic receptors or on the splenocytes, okay, on the spleen cells. This contributes to what? It contributes to two things, splenic atrophy and T cell apoptosis, which is explaining to us the reduction in the circulating lymphocytes, the lymphopenia, the one that we talked about here, the lymphopenia. Okay, so it's caused by this. The second one that I'd like to talk about is the HPA, or the hypothalamic pituitary adrenal axis. The activation of this pathway will give me the cortisol or the glucocorticoids. These glucocorticoids, they will promote the lymphocyte apoptosis, which will increase the anti-inflammatory cytokine and suppress the pro-inflammatory cytokines. And the third one is the parasympathetic nervous system, the PNS. This is a cholinergic pathway, okay? It's a cholinergic pathway. And it's particularly using the vagus nerve, which prevent excessive immune activation. So it will suppress the pro-inflammatory cytokines, including the TNF alpha. So, for example, if you want a simple way to be able to recognize the immunosuppressive state, we need to remember that the lymphocytopenia and the anti-inflammatory cytokines, they will give me immune suppression. Okay, this one. Now let's talk about secondary thrombotic complications. Now, this complication comes from the interaction between inflammation and coagulation. After a stroke, we have sterile inflammation that will activate for me the innate, okay? It will activate for me the innate immune cells, such as the monocytes and the neutrophils. This inflammatory activation will stimulate for me the coagulation cascade, which will give me thrombus formation. But this relationship is actually going both ways. The inflammation, it will promote for me, the inflammation, it will promote for me what? Coagulation. And coagulation will amplify or make it more for the inflammation. So these two processes, they are potentiating each other. They are magnifying each other. عم بيكبروا بعض. So the result can be what? It can be either additional ischemic injury and secondary thrombotic complications, okay, in this case. Now, this can manifest as things such as recurrent stroke or myocardial infarction. So stroke doesn't only increase the risk of complication inside the brain, the systemic inflammatory and coagulation response can also affect the organs that are outside, see, the myocardial infarction, for example. And this is a sign of the secondary thrombotic complication. And we discussed how is it happening, how the inflammation is amplifying the coagulation is amplifying the inflammation. Let's talk about a most important um, aspect here, which is the gut-brain axis. What do we need to know about it? Approximately about 50 to 60% of stroke patients that have gastrointestinal complications. Now, these can include what? These can include altered intestinal mobility, microbial dysbiosis, and intestinal bleeding. Why is this happening? Stroke can affect the autonomic nervous system, okay? And increase beta adrenergic signaling can interfere with the normal production of what? What could you think? Of the intestinal mucin. Now, the mucin is important part of the intestinal barrier. It's important for the intestinal barrier. When this mucin production is disrupted, what will happen to the intestinal barrier? The permeability will increase. And this is why we call it a leaky gut. So the key sequence here, whenever we have stroke, it will affect the autonomic changes, alter the beta adrenergic signaling. It will disturb the mucin, gut permeability increase, and leaky gut will happen. And once the gut barrier become compromised, the bacteria will start coming here. We call it bacterial translocation. Now, let's talk about the gut barrier and the infection. Once the intestinal barrier become more permeable, the bacteria from the gut can actually cross the barrier. We said it's bacterial translocation. Now, the bacteria can reach the circulation in other organs, such as what? Such as the liver, the lungs, the blood. Now, remember that at the same time, the patient may already have blood-brain barrier disruption and significant subacute immunosuppression. Okay? So we have two problems happening together. The barriers that normally protect us are being compromised, while the immune system that normally fight the infection is being suppressed, immunosuppression. And this combination that we are seeing here is basically explaining why infection are such an important complication after stroke. What do I mean by that? Approximately 30% of stroke patients can have infection, can develop infections, particularly the respiratory and the urinary infection. And these infections, they will increase what? They will increase for me the mortality rate and can interfere with the neurologic recovery, and this risk will actually increase with the age. So all of this is related. I hope it makes sense. Let's talk now about the last phase, which is the chronic phase. And this one develops within days to months. At this stage, we're no longer dealing with the initial acute inflammatory response or the temporary immunosuppression that happened in the subacute phase. Instead, some patients can develop persistent inflammation, systemic inflammation. So the DAMPs and the inflammatory cytokines, okay, they develop resistant immune or systemic inflammation by being elevated, or not actually like elevating and decreasing, no, they remain elevated. These DAMPs and the inflammatory cytokines. Another very important concept, which involves the activated T cell as well, that if T cell become activated against the brain antigen, they can cross what the CNS, even when the blood-brain barrier is no longer actively leaking, they can still cross it. This is an interesting fact. That's important because why? Because activated T cells, they have different mechanism to enter the CNS. This means that the immune response can continue even after the blood-brain barrier disruption have been resolved. So even if it's not leaky yet or leaky anymore, it can still cross. So the persistent immune activity and inflammation, it contribute to long-term complications such as atherosclerosis, cardiac dysfunction, diabetes, post-stroke dementia, fatigue, and depression. So the immune consequences of stroke can potentially extend for beyond the time limit or of the neurological event or the time limit that we already have in mind. Now let's talk about the autoimmunity after the stroke. So, can a stroke actually cause an autoimmune disease? Can it? The answer is that the relationship between them is not actually firmly established in this case. Okay, so we should be careful not to say that stroke will lead to autoimmune diseases. Don't say it. It's not like an equal. It's still like not firmly talked about. However, we have a mechanism that we need to talk about. So, for example, whenever the brain antigen enter the circulation, they can stimulate the B and the T lymphocytes in the peripheral lymphoid organs, okay, such as the spleen and the lymphoid nodes. Some of these activated lymphocytes, they become reactive against the brain component. These lymphocytes can then go back to the brain. Once there, they may contribute to chronic inflammation and cytotoxicity. So based on the sequence, if I have, for example, let me simplify it. If I have a brain injury, okay, and I have the antigen exposure, and it leads to lymphocytic activation. We said some of them can actually what? Some of them can be active against the brain, so they will go back to the brain, return to brain, and this could lead to a chronic immune activity. Immune activity. But this doesn't actually say that 100% all of it will lead to autoimmunity. Okay? Uh, now Yeah, so here during the second week after stroke, peripheral lymphocytes may show increased activity against myelin. So I try to simplify the slides as much as possible. You can also take a look at the slide and read it as I am explaining, and I hope it makes sense to you. Now let's go and talk about the post-stroke autoimmunity. An important point here is the response is often transient. In many cases, the patient recovered, the autoimmune response also will go away, it will subside. The problem is when this response become persistent. So this is the problem when it becomes persistent. Persistent autoimmunity, it will interfere with the neurological recovery and it will worsen the degeneration and promote chronic inflammation. There are several factors that may influence whether this happen or not. This includes what? The risk factors such as the genetic predisposition, such as the HLA types, the severity of the stroke, the extension, how extensive the blood-brain barrier disruption was, or pre-existing conditions or medications. All of them can actually determine whether it will be transient, will go away or not. Another interesting finding is that during the second week after stroke, the peripheral lymphocytes, they may demonstrate an increase in the activity against myelin compared to the healthy ones, and even compared to the patient with multiple sclerosis as well. So it's happening in the second week after, not before, after stroke. The lymphocyte can have more increased activity against myelin. Okay, so the key here, the key idea isn't that every stroke patient will have autoimmune disease. The key here is that the stroke can create an environment, whether it will be transient in some patient or persistent according to their risk factors. Now let's talk about the long-term cytokine profile. What happens to the inflammatory markers over the long term? The several cytokines and inflammatory biomarkers can remain elevated for as long as 3 months after stroke. For example, here we have interleukin 6, 1 beta, HMGB1, MCP1, CRP, interleukin 4, and interferon gamma. You don't necessarily need to memorize every single one, but the important thing that you need to understand is that the inflammatory response can actually persist for beyond the initial hours of stroke. As we've seen here, it can stay for up to 3 months. And the magnitude of this response is related to the severity of the stroke. What do I mean by this? If it was larger and more severe stroke, I'm gonna have greater inflammatory response. So the stroke severity is actually important to determine the immune response. Now let's talk about the monocytosis in the cardiovascular risk. Another chronic immune change after the stroke is monocytosis, which means what? An increase in the circulating monocytes. And this matters. Why? Because the monocytes, they're important inflammatory cells and they are associated with the vascular inflammation. Therefore, the post-stroke monocytosis may increase the risk of the cardiovascular complication. And this is important in patients who have pre-existing what? Pre-existing atherosclerosis. So we're seeing that the inflammatory response after stroke is not actually confined to the brain. It could actually lead to the cardio effects, for example. And yeah, so this is it basically for this slide. Let's talk about the post-stroke dementia. So it's also another long-term complication. There is a growing relationship between what? Between chronic inflammation, adaptive immunity, and long-term cognitive decline after stroke. It's been researched actually. So they've seen that in some patients, activated microglia and astrocytes and lymphocytes can actually remain present in the brain for a very long period, even decades after the stroke. Can you imagine? Even after the stroke resolved, they can stay. Now, this can contribute to what? To the loss of integrity of the neural network. And over time, the brain region will undergo atrophy in this case, and it can present as cognitive decline, fatigue, or depression. So the important concept here is that the consequence of stroke can continue long after the infection. We've been repeating this and mentioning it multiple times. For the take-home message here, the immune system is a double-edged sword. We need to know that because during the acute phase, the immune response is actually activated. The microglia and the astrocyte become activated. The DAMPs will be released. The blood-brain barrier will be distributed, and pro-inflammatory pathways will also be activated. And at this stage, you're going to have excessive inflammation and contribute to secondary brain injury. So, therefore, our goal would be to suppress the excessive inflammation. Then for the subacute phase, the problem here reverses. We called it the op. Why did we call it the op? Because it developed immunosuppression, lymphopenia, a shift between T helper 1 and T helper 2, reduced inflammation, could be beneficial for protecting the brain, but also worse because it make it more prone to infection. We're just repeating ourselves here, basically. And we need to support the immunity and prevent the infection in this case. And lastly, in the chronic phase, the adaptive immune response and persistent inflammation, it will contribute to long-term complication like autoimmunity or neuroinflammation. Okay. And the goal here is to monitor for chronic inflammation and autoimmune effect. So we cannot simply say that stroke, okay, will cause inflammation, so suppress the immune system. No, the immune response is changing throughout the phases, as we've seen. And what may be beneficial during one phase could be harmful in the other one. So in each and every phase, we have different stuff, different treatments. Now let's talk about the clinical adaptation. Okay, what does this all mean clinically? Okay, targeting post-stroke inflammation will be considered like therapeutic strategy, but it also could improve the patient outcome and reduce some of the complications that happen after stroke. Okay, now the goal would include, like, for example, to improve the neurological outcome, prevent the recurrent vascular event, reduce the secondary complication and the chronic complication to prevent them. But there is a very important challenge that we need to mention because the immune response is changing over time. Okay, so it's changing over time. We cannot use the same exact immune targeting treatment. So in the future clinical trials, they are considering the stage of the tissue damage, okay, when deciding what to use, for example. So imaging could, for example, help in assessing the inflammation um, to be better and targeting an immune response that is suitable for each and every phase. So the right immune target and the right patient and the right phase of stroke. Lastly, for the final summary here, we start with the stroke, obviously, and then during the acute phase, we are going to have the cell death, the DAMPs, the microglia and astrocyte, BBB disruption, inflammation, and then this active microglia and astrocyte will do its job in this case. Okay, then in the subacute phase, we're going to have the sympathetic and the HPA axis, a shift between TLPRO and TLPR2, and immunosuppression. We called it the OP. And lastly, the consequence, okay. Uh, oh wait, before we can move on here in the subacute, again, we need to mention that what? The inflammation and coagulation can interact and contribute to thrombosis. This is the inflammation coagulation can lead to thrombosis in this case. And lastly, in the chronic, we have persistent DAMPs and cytokines and adaptive response can continue to affect the patient and can lead to autoimmunity, atherosclerosis, cardiac dysfunction, dementia, fatigue, and depression. So, if you want to leave this lecture, we need to remember this stuff. We need to remember also that stroke will not give me only one immune response. It is dynamic, okay? It will give me a multi-phase cascade. First activation, and then the suppression, and then the chronic inflammation. And the most important thing to note that the immune response could either be protective or it could be harmful. So it's very important to understand these concepts. Thank you very much for listening to this lecture. I hope it made sense. Have a nice day.